So first and foremost, so the women leaders that were responsible for getting me here today, where are you? Can I figure out and say thank you? Because I had a number of them actually approach me all day yesterday and say, we came back and we wanted to make sure that you were here, so here I am. All right, so good morning again. As was mentioned, I am Admiral Aisha Mix, and I serve as Chief Nurse of our United States Public Health Service. The video that you saw is one that I've seen a number of times, but every single time I see it, it reminds me of exactly why I serve. So I bring you greetings on behalf of our Surgeon General, Vice Admiral Vivek Murthy. I report directly to the Surgeon General, and what I emphasize to him and to the Secretary of the Department of Health and Human Services is the role that nurses and the nursing profession can play in really moving forward and addressing the nation's health priorities. So as a service, we stand as one of our 8 uniformed services in this country. Most people are familiar with the military. As a matter of fact, I had a woman in the elevator this morning and she said, oh my goodness, you look so sharp today. Are you in the military? Sorta, right? So there are 8 uniformed services: Army, Navy, Air Force, Marines, Coast Guard, Space Force, and then there are 2 that are uniformed, right? So I have not been trained in combat. I have not been trained to protect this country except by way of health. So we are the only uniformed service whose mission is to protect, promote, and advance the health and safety of this great nation, right? So we are a number just under 6,000, and what we serve to do and what I call our day jobs are really provide care and services to the most vulnerable and underserved of our populations across the country. We serve in a variety of federal agencies, some state agencies, both in the United States and across the globe. And in many places and spaces in these agencies, what we're charged with is developing policy, healthcare programs to, again, address those issues and priorities that I mentioned previously. By way of number and categorization, we are actually split into 11 different professional categories. There's one highlighted. I bet you can't imagine why, right? I'm a little biased. However, we do have 11 different categories. The top 3 by number: pharmacists are number 1, nurses are number 2, and then what we call our health services category is number 3, and that is actually a multidisciplinary category. Most of you will be familiar with the term allied health. So many of our allied health type professionals, to include social workers, podiatrists, physician assistants, epidemiologists, health information managers, are all a part of our health services category. However, what's important to take away from this slide is that none of us can do what we do alone. We work collectively, again, to protect, promote, and advance the health and safety of our nation. So, as public health professionals, I want to just take you on this walk with me, kind of from where public health began to where we are now. So if we look all the way back to the 1800s, right? So this is when we're first discovering what public health and the impact of our environment has on the health of individuals. And so we're understanding this distinction between medicine, between public health, but what we were doing was still keeping them quite fragmented and segmented. And so we had medical care, we had public health care, but we were not yet at a point to integrate. Fast forward a little bit to the 1988 IOM report and the future of public health, what we realized is that we actually have to create a more centralized system for how we take care of the people in this country, right? So at that point, what we started seeing is more coordination and what many of you are familiar with as our state-based public health organizations, right? So those came into play, but then what we realized is now we're a bit too centralized. And we're a little bit too focused on exactly what we do and for only the people that we serve. So Public Health 3.0 then, right? At that point, we started to realize all of the other factors outside of medicine, outside of public health, that impact a person's health, right? So I represent the United States Department of Health and Human Services, and many times people forget about that second H. We talk about health, but we don't always talk about human services, which are those wraparound things, right? So if health is life-saving, human services is life-sustaining. So introduce this concept of social determinants of health, right? And so with Public Health 3.0, we started to look more at the whole person and the whole community to understand this thing called health, right? What we also did at that time was recognize that somebody actually has to be in charge of this. And there was a role that was considered, and it was called the Chief Health Strategist. And the importance of this role was that there was someone who was looking across the community to understand how do all of the pieces of this puzzle come together in a way that serves all of the people. We're still working on that, right? More to come, right? But what I will offer, though, is this shift that I just described is what moved us from a focus on clinical intervention and place-based care. I say all the time that many of us were born in hospitals, however, we don't live there. So what ends up happening is when we focus our care delivery systems and everything that we do on a hospital-based model, we're putting too much at the wrong time of the conversation. We have to actually begin to move towards a conversation of meeting people where they are, where they live, which are in our communities across the globe. So it's not until then that we can get to a point of really discussing how to get ahead of what we consider health. Because we have to choose on whether or not we are looking at wellness or illness. Is it a health promotion model or is it an illness-focused model, right? There's room for everyone. However, we need to actually even this playing field a little bit. So what I say is that what we're really looking at is identifying how we can leverage health IT and our metrics to make sure that we are including these social determinants of health. To understand, and even as Don mentioned, as we're looking at the fusion and making sure that we're addressing the needs of our professionals, how do we then translate that same experience to the experience of our patients? That will actually take understanding the world in which they live so that we can understand what's in the way, so that when they present, we can actually do a better job of incorporating everything that we know about that person to include where they came from, and if they do end up in the hospital, where they're going back to, so that we can make sure that we are actually acknowledging the whole person and not just a point in time. So when I stepped into this role as the United States Public Health Service Chief Nurse Officer in October of 2019, I came into this position with a set of priorities that I wanted to focus on as chief nurse, right? So in addition to advising the Surgeon General, I also represent the Department of Health and Human Services on the world stage as part of the government chief nurse officers and midwifery officers in the International Council for Nursing and the World Health Assembly. So I speak on behalf of all of the nurses in the United States in that position. And so what I said was that I want to make sure that we're promoting nursing as a profession so that people actually understand what we are as a profession and not just individually as nurses, right? I also wanted to mobilize nurses to address the SG's priorities, SG, Surgeon General, right? And then lastly, recruit and retain public health nurses. As a public health nurse by specialty, that was incredibly important. As a senior leader in the public health service, you can imagine that that is incredibly important, right? But I also identified some health challenges that were foremost on the brain, right? So access to health care, workforce diversity, community preparedness for disasters and public health emergencies, as well as addressing known health disparities and inequities, right? And if you caught what I said, I came into this position in October of 2019. I'm not sure if you all remember what happened around February, March of 2020. Imagine to my surprise, and let me back up to say that 2020 was actually identified as the International Year of the Nurse and Midwife. So I came in October 2019 as chief nurse, ready to take on January 1, the International Year of the Nurse, because that's me. And then there was this pandemic. And though it threw us all for a loop, by virtue of this slide, you already know that it wasn't new, right? As a public health nurse by training, none of what we experienced was new, and it wasn't new to anyone except for those who had not already been operating in this space, right? So understanding, and we could probably debate all day long about what went right, what went wrong, and everything in between, but what I offer is that it really forced us to take a better look at not only what we were doing, but how we were doing it and who's doing it, right? It also forced us to understand that we were actually not doing as good a job as we thought we were. And many of those things were exposed. So in the remaining time that I have with you today, I have a couple of takeaways that I want to make sure that when all is said and done and I walk off that stage, that I leave these things with you. So first is a greater understanding of the nursing profession. Many of you, if I asked you, what does a nurse do? You'll give me the experience that you had, or a family member of yours who's a nurse. Very few can actually explain what nursing is as a profession or what nurses truly do, right? The next thing is an understanding of the interrelatedness of social determinants of health and how they actually are the often forgotten metric when we talk about policy development and program management. And then the third thing is a commitment from each and every one of you that as you go forth, not only this week, but continuing on in your careers, and especially as it relates to health IT, that you have a commitment to utilize health IT to carry the message of the people and not just a message about the people. Got it? Got it? Good. All right, so first thing, as a nurse, what am I, who am I? Now, this actually represents only 3 areas of our healthcare system. Clearly, I don't have enough screen space, even with a screen this big, to outline all of the players that are at the table in healthcare. But I chose to choose a couple that you might know a little bit about. So one of the things that's important to understand is that many people are familiar with medicine, right? So familiar with medicine as a well-established profession with a very sharp public image. Some of you may also be familiar with public health, right? But public health is actually a variety of disciplines. So it's very hard to figure out what the image is for public health and who's doing the work. So a very diffuse public image with multiple professions. In nursing, we live somewhere in the middle. We have a sharp public image, right? We remain the most trusted healthcare profession for a number of years. However, we still have a diffuse public image. Somehow we still have a problem really understanding what nurses bring to the table. So what I want you to understand is that nursing is the art and the science of caring. What does that mean? What it means is that as a nursing diagnosis, what I'm focused on is the human response to the environment around the person. So not so much the diagnosis that they were given, but how did you hear that? How does that make you feel? And more importantly, how can I help you manage that, right? So that's where nursing lives. So it's a conversation that really brings in a focus on advocacy and humanity for all people, whether that be an individual, a group, a population, or a community. The other piece that's important to understand is what we do is informed by the biological, psychological, social, cultural, and spiritual aspect of a person. And that's what brings in all the sciences as listed on here that inform our education and training, because it is a marrying of the clinical science as well as the social science, because again, I say it's important to understand the whole person. What's incredibly important to understand, nursing and nurses exist wherever there are healthcare consumers who are in need of information and or advocacy. Because what we do is make sure that where the rubber meets the road, which is the patient, that the impact that's experienced by that patient is actually what was expected, anticipated, and projected by any provider or any community level service. So I offer this as a summary, as a comparison, but also in hopes of enlightening you to how you can better utilize nurses and the nursing profession in engaging in the work that you do, especially if your goal is to actually improve and optimize the health of people. So I mentioned social determinants of health. For some, this is old news. For some, it might be fairly new. I tell nurses all the time that social determinants of health as a term is fairly new. However, it's our bread and butter. It's what all of us were trained to do and address, as I said. So if we start on the far side to my right, as social determinants, what we're talking about here are those circumstances within which people live, learn, work, play, and pray, right? So it's really the context in which they do life. And so according to CDC and many others, when we break down these particular areas, there are a couple of different things to consider. Your social and community contexts are your network, who's around you, your family or lack thereof, right? The experience you have engaging with people in your respective community, to include any experience with racism, discrimination, or other structural and systemic barriers. A conversation of education, access, and quality is how much do people have an opportunity to excel in order to make a life for themselves. One example I utilize is, students who graduate from different high schools and both have 4.0 GPAs. However, one had access to college prep courses and another one did not. And so your 4.0 actually sounds the same, but operationalized, it looks quite different for what you're ready for if you choose to go to a college environment, right? Unequal playing fields. Another, economic stability and the ability to take care of yourself and your family. Environmental concerns that relate to how well you can get around your community, because if I tell you to get healthy, go exercise, you'd actually have to have streets, sidewalks, roads that are safe for you to travel. You have to live in a community where it's safe for you to be outside, right? And lastly, healthcare access and quality. Again, another factor that we tend to assume. However, and if I live in a community that has a limited number of providers, it may take me longer to get an appointment. Depending on where they're located, I may or may not be able to get there. And oh, by the way, if I work a full-time job and their hours mirror mine, pray tell, when do you expect me to actually make an appointment? So when I say social determinants of health, what I'm talking about are those factors that impact people's health, but are largely outside of their control. Right? So when we move to the center part of this particular slide, this is where most people talk about health, right? And they start in with a conversation that talks about the health behaviors and the actions that people have taken without taking into consideration all the things that I just said previously, right? So imagine the mental health and well-being of someone who is constantly every day, again, fighting a racism or prejudice in their community. How well prepared do you believe they are to engage with the additional challenges of life, right? That person who went to the provider and they did everything they needed to do, and what they were told is eat better, change your diet. But no one actually stopped to find out if they could actually afford more nutritious foods, or if there were even nutritious options in the community where they lived, right? So of more concern is when you move even further to the left-hand side of this particular slide, that's where we live most often in the world of data. So the stories that we tell are actually focused more so on quality of life, morbidity, mortality, life expectancy. What I'm offering to you is an opportunity to actually focus more to my right, right? What does it look like to build into all of our paradigms this conversation and level of understanding that takes into consideration the context within which people find themselves? What can we do to ensure that data are so robust that they include these kinds of conversations by way of informing policy, program development, whether that be government, state, or otherwise? But again, most of the data are utilized at many different levels to drive, again, policy, innovation, science. Imagine if, or as my daughters say, imagine a world where we were telling the full story and not just only the part that we had available to us. So what does this look like as we move a little forward, right? So I just chose to pull out two different examples of what this looks like in action. So the first one is the Satcher Health Leadership's Health Equity Tracker. This is out of Morehouse School of Medicine in Atlanta, Georgia. And what this tracker does is it actually pulls some social determinants into data that is overlaid with race, ethnicity, socioeconomic status, and it gives you a picture down to community levels when it is available. More important than the data that are available here are the data that are not, right? It's the idea that there are segments of our population for whom we have no data. How then do you tell a story for people who are not represented, right? Moving over to our social vulnerability index and understanding that social vulnerability index identifies those communities who are most at risk at times of public health emergencies or disasters. Again, it overlays these social determinants so that you can see who's most at risk, so that you can target the resources that are available for these communities. One thing to let you know, both of these are publicly available. Even the Health Equity Tracker is open source and available to everyone. So as I begin to close, this is really where we're trying to get, right? We're trying to get to a place where we have one public health community that can actually engage with healthcare, communicate meaningfully with the public, improve health equity, and give us all a means to protect and promote health, right? So we have to be able to account for these social factors that impact health, again, where people live, the environment, their income and jobs, discrimination they face, and their access to health care. We also must begin to share these best practices, real-time, robust, comprehensive data, timely and complete data. And so I left you off at Public Health 3.0, but I want to introduce this concept of Public Health 4.0 because it is brewing. As we experience the joint crises of a pandemic and racial tensions, we're moving into a level now where we actually have to overlay and account for these health disparities by way of what's in the way through systemic racism and injustices. So in addition to everything that I said, I leave you with that as well, right? And so I bring you back to what I said before, is that what's most important in these conversations is really centering those who are most impacted by your work, addressing the more upstream causes of illness and disease as opposed to blaming, if you will, the person, and ensuring again that the future of health IT is of the people and not just about the people. And with that, I say thank you, and I wish you the best in the continuation of today's conference. Thank you.